Good morning, everyone, and welcome to the session on neoplasm. And I would like to call upon Dr. Muralidhar Sharma, sir, Professor Emeritus, Department of Cell Engineering, SGMC Udupi, to take over the session. Welcome, sir.
Hmm. The next is about hello. The next is about the endometrial cancer, and the endometrial cancer is also referred as a corpus uterine cancer or corpus cancer, and it's one of the most common female genital cancer in the developed world. In the Western country, it is more common. Of course, it's also common in India, but India comes in fifth place. Endometrial cancer is the sixth most common cancer in women worldwide, and approximately 70% of the women of endometrial cancer are postmenopausal, and hence the most common symptom is the postmenopausal bleeding. As per the data, India also has one of the highest high numbers of the endometrial cancer, and as per the data, China has number one, and US, Russia, Japan, and then comes India, fifth position. The incidence in 2022 in India, as per the reports, now this is about the reported cases of the endometrial cancer, it's 17,240, and the incidence is quite significant. And the incidence of endometrial cancer also is increasing year by year. Now these are from the global one, and as per the age, it's also a disease of the old age, that's usually the postmenopausal, and the maximum incidence occurs after the age of 60. Now in 2019, 60, 64, the number of cases reported were this dotted line, grey line, whereas 2010 and 14, somewhat recent, the number is increasing as such. Now of course, if the current 2024 data is seen, it could be still higher. So that's one of the rather type of the cancer which is increasing in number. Causes for the endometrial cancer are many. There are certain interesting aspects as such. The endogenous factors like obesity, nulliparity, that's those who never had a child or never have become pregnant, and they have a high incidence of endometrial cancer, and having late menopause, that's menopause even after the age of 52 years, is also a high chance of endometrial cancer. These are certain of the endogenous factors for which the real cause and effect relationship is not known. Then another quite important cause is estrogen supplied from other sources, external sources. Estrogen could be supplied for certain disease conditions as a contraceptive, or estrogen also could be provided in the hormone replacement therapy or HRT after the menopause, and that increases the incidence of endogenous cancer. Patients who are on oral contraceptives also are having a high chance of endogenous cancer. Now, very interesting is with the cigarette smoking, unlike other cancers, cigarette smoking is supposed to be a cause for increasing the number of cancers. But there is a reverse issue in case of the endometrial cancer. This is only about the statistical observation. The real reasons are not known. But as per the statistical observation, smoking apparently decreases the risk of developing endometrial cancer, and the effect of smoking are related to the body weight. Heavier women who smoke have a greatest reduction in the risk. So this is a very issue which looks like paradoxical. In general, smoking is considered to be a cause for majority of the cancers, but statistically, endometrial cancer is seeming to be lesser in the person who smoke as such. But this fact is purely a statistical fact, and it's not yet having any this rational background studied based upon the biochemical parameters. But anyway, it's a very interesting observation. So that's one of the issue. Then other medical conditions like patient who have a cancers of the breast, colon, or ovarian cancers also are having a high chance of endometrial cancer. There is a possibility of family history, and the family history is those who have endometrial cancer in the family, they also have a high chance of endometrial cancer. There is a tendency in the course of the disease based upon the your types, the personalities, as well as the genera. Its mortality is higher in black women, that's 8.3 deaths per 1 lakh, and then in white women, Asian and Pacific Islander women, Indian people, who have they have a much lesser chance of death rate, 2.9% deaths per 1 lakh among all races. The other risk factors which are known, there are certain of the risk factors which are known to be a cause for the endometrial cancer, and among them the chances of number of folds of increased risk factors. Patients who are on estrogen only hormone replacement therapy, that hormone replacement therapy given postmenopausally, if it is only the estrogen given, then the chances would be of having that endometrial cancer would be almost 2 to 10 times more than the average population. If the patient is obese, then that risk increases up to 20 parts or 20 times that of the average population. Patients who have PCOS or chronic anovulatory pathologies in the younger age, they have 3 times more chances as such. Patients who are at tamoxifen is one of the hormone suppressive therapy usually given after the treatment of cancer of the breast. In such conditions also the risk is around 2 to 3 times more than the average population. Nulliparity, that's having no issues, the risk increases about 2 to 3 times. Early menarche and late menopause. Now, this is another of the issue. Those who have started menarche at very early stage, they also have a high risk of developing endometrial cancer, and the risk is almost doubled or 3 times more. Hypertension and diabetes also increases the risk as such. Now, approximately 75% of the men with endometrial cancer are postmenopausal, and the most common symptom is postmenopausal bleeding. The duration or amount of the blood doesn't make any difference. So, if a patient of postmenopausal period presents with the bleeding, whether it is a small quantity, simple staining or gross, the patient needs to be evaluated thoroughly. So, postmenopausal bleeding is always a cause of concern. And the causes for these postmenopausal bleeding are, majority of them could be atopic endometritis or vaginitis. Patients may have 60 to 80% may be having that vaginitis. Patients who are on exogenous estrogens, like estrogen provided from other sources, administered from other sources, it could be in 15 to 25% of the patients. The carcinoma constitutes around 10% of the patients. Endometrial cancer is 10% of the patients. Or there could be the precancerous conditions like hyperplasia in large number of patients, endometrial hyperplasia, which is around 5 to 10%. Now, endometrial hyperplasia and endometrial carcinoma, the difference is very thin, borderline. It's mainly based upon the microscopic image or that of the ultrasound image assessment of the thickening of the endometrium, and all patients of endometrial hyperplasia also have to be cautiously followed up for the possibility of developing a carcinoma in due course of time. Then the other conditions like cervical polyps constitute around 2 to 12%. The important is every patient of postmenopausal bleeding, irrespective of the quantity of the blood or irrespective of the duration, they need to be evaluated and confirmed to be the cause. Vaginitis or endometritis, it's a easily treatable condition, whereas the other conditions like exogenous estrogens, they can be managed, like if you can withdraw that estrogen hormone supply from other sources, it can be managed. But important is to rule out the carcinoma conditions as such. So one of the important precautions is every patient of postmenopausal bleeding has to be assessed thoroughly, and the carcinoma has to be ruled out. Then 25% of the endometrial cancers in patients who are perimenopausal or premenopausal, and symptoms suggestive may be very subtle. The diagnosis of endometrial cancer becomes difficult. The criteria to make the diagnosis would be only the bleeding, and it's only the bleeding patients who are evaluated. Then there will be the evidence of endometrial cancer, and almost all patients or majority of the patients would not have any other symptoms other than that of the bleeding till very late stages. Only when there is a secondaries or the involvement of the peritoneum where there would be ascites, then the diagnosis may be possible in other signs, but the primary clinical symptom would be bleeding per uterus or bleeding per vagina, and that too postmenopausal or premenopausal, very close to the menopausal age. In such conditions, they need to be evaluated thoroughly, and the histological examination is necessary. To confirm the diagnosis other than that of histological diagnosis, ultrasound is considered to be one of the standard parameters, and there again in the ultrasound, transvaginal ultrasound is much better than the usual conventional ultrasound which we do quite frequently. In the ultrasound, there is another of the two modification, sonohysterography, which is now becoming popular in sophisticated centers. Of course, in our center we don't have that facility. In that, they inject saline, and then which helps in separating the uterine wall, and hence the endometrium can be evaluated. MRI is the other optimal imaging modality to assess whether there is a myometrial invasion or not. So, MRI primarily doesn't help in making the diagnosis, but once the endometrial cancer is diagnosed, to confirm the extent of the tumor invasion, MRI is better. And the CT and PET scan would be to detect whether there are lymph node involvement or not. Now, the primary ultrasonographic findings would be as seen as a thickening of the endometrium. So, diagnosing a abnormally thickened endometrium depends on patient's point in menstrual cycle, or in postmenopausal. If it is more than 5 millimeter, it is thickened, and more than 8 millimeter if on hormone replacement therapy or tamoxifen. That's the primary criteria to confirm whether there is a real thickening or not. In a patient who is actually menstruating, the phase of the menstruation is one of the decisive factor. At the second half of the menstrual phase, the thickening of endometrium is a normal phenomenon, whereas in the first half or post menstruation or post bleeding, the thickness of the endometrium would be very low, less than 2 millimeter, and hence when a ultrasonologist gives a report, you have to look at that report based upon the menstrual phase of the menstrual cycle in a menstruating woman. In the postmenopausal, the criteria is more than 5 millimeter is considered as a thickened, abnormally thickened. If the patient is not on hormone therapy, if the patient is on hormone therapy, 8 millimeter is considered to be the standard criteria. The other findings, other than that of the thickening, the other findings which could be seen are heterogeneous or irregular endometrial thickening. I will show you some examples, or polypoid mass lesions, or intrauterine fluid collection, or frank myometrial invasion seen in the ultrasonography could be the criteria. So, ultrasonography is one of the dependable means of diagnosis, and hence I will just give you a bit more about that. Abnormal ultrasonographic features which could be suggestive of the endometrial pathologies. The endometrial cancer would be, the thickness of the endometrium would be 11 to 26 mm, or much more than 11 millimeters, and there could be increased vascularity. Atypical hyperplasia, if it is in between 8 to 18 millimeter, is considered to be hyperplasia. Up to 8 millimeter, it can be presented in postmenopausal women on hormone therapy, or in the premenopausal conditions during the end phase of the menopause, it could be up to 8 millimeter. 5 millimeter in patients who are not on hormone therapy, that would be the criteria to make the diagnosis. Now, in addition to this, the other patients, other conditions which may have a bleeding per vagina, could be leiomyoma, where there could be localized masses which could be seen under ultrasonography, or a polyps which are seen in the ultrasonography, like again finger-like projection seen, or hyperplasia of between that moderate 9 to 17 mm, which is considered as the end of the conventional hyperplasia, or simply proliferative phase, that's the phase of the menstruation, the first phase of the menstruation, end of the first phase of the menstruation, or beginning of the second phase of the menstruation. It will be 6 to 13 millimeters as such, and patients who have atrophy, it will be in between 1 to 7 millimeter. The features which could be seen on ultrasound image, this also is important, because many times we may get an opportunity to see the ultrasound image. Reports of the ultrasoundologist may have to be reviewed based upon the image. So, in a patient who has a heterogeneous or irregular endometrial thickening, so endometrium and the thickening is irregular, the chances of malignancy is more. The patients who have intrauterine fluid collection, presence of the fluid within the intrauterine, it almost is uterus cavity with the irregular borders, endometrium, it's almost a confirmation of the endometrial cancer. Or patients who have polypoid lesions like small projections which look like polyps, here as you see over here, that's the sign of either a malignancy, or if it is involving the myometrium, the hypertrophy involves myometrium also is partially damaged. In that condition, it's again confirmation of the tumor pathology. For grading of endometrial cancer, if you have suspected, ultrasound Doppler studies are the major criteria to make the diagnosis, and staging also is done based upon that, and the stages seen as per the image and the signs of vascularity. When there is a maximum vascularity and the thickness is quite high, around more than 16 mm, then it's called as stage 2 or grade 3, and the others are considered stage 1A or stage 1B with grades as stage 1A grade 1 or stage 1A grade 2 based upon the thickness. That's what the ultrasonologist should report. The MRI scan helps in identifying the invasion, the thickness of the myometrium, and the involvement of the endometrium and the myometrium differentiation is easy to be made out. Presence of that abnormal thickening can be made out, and whether the lesion involves the myometrium or not, that also can be made out with the MRI scan. And the CT helps in identifying the lymph nodes. That's mainly to identify the lymph nodes, but it cannot identify the primary lesion. The uterus differentiation may not be possible with that, but lymph nodes can be better made out. Of course, PET scan, as in any case of the tumor pathology, it shows the tumor activity that increased the vascularity, as well as the possibility of the lymph nodes involved in the periphery. The ultimate, the final will be endometrial biopsy. For the endometrial biopsy again, either it could be a fractional dilatation or a full dilatation which is done with the curettage. The ideal is where you have a definite evidence would be a full dilatation which you call as D and C. Fractional dilatation is just a part dilatation. You will not use a Hagar's dilator, but you usually use a smooth cannula, and with the cannula you may curate the endometrium, and that is also helpful. And now as far as the reliability is concerned, a full dilatation DNC is considered to be more reliable, but fractional dilatation also would be good enough because it's a relatively simple, less invasive procedure. Suppose a patient has a clinical signs of bleeding persisting, then the patient has to be observed further. And if the endometrial pathology is not confirmed by biopsy, and the patient has no further bleeding, then there is no need of additional diagnostic tests as per the standard guidelines. Suppose a postmenopausal patient had an episode of bleeding, and then you have done a dilatation once and curettage doesn't show the evidence in the biopsy, then there is no need of follow further. That's the criteria which is the general guideline which is suggested by FIGO. And if the patient continues to be symptomatic, suppose the patient has still episodes of bleeding, then the further evaluation is necessary. So ultimately, the diagnosis is dependent upon the clinical course of the bleeding, and particularly postmenopausal bleeding. The most dependable method of diagnosis is a hysteroscopically directed biopsy, where with the view you can select the area and then make the biopsy, take the tissue for the biopsy and confirm the diagnosis. The mode of spread of endometrial cancer is either by direct spread, which accounts for almost the local extension beyond the uterus, where the myometrium, and then beyond the myometrium the pelvic structures could be involved. Lymphatic spread results in involvement of either the pelvic, para-aortic, or rarely inguinal lymph nodes also. Hematologic spread is responsible for metastasis in the lungs, liver, bone, and brain. It's rare, but lungs, liver are common. Peritoneal spread also results in intraperitoneal implants, where particularly in the serous carcinoma, it may be observed in the whole of the peritoneum. The staging of endometrial cancer based upon the FIGO, that's the Federation of International Gynecology Obstetrics as such. The staging is stage 1, 1A. Stage 1 is tumor confined to the uterine corpus and ovary only. 1A is limited to the endometrium but and non-aggressive histological type. Stage B is non-aggressive histological type with more than 50% of the meiometrium invasion. Stage 1C is aggressive histological type with a polyp or a confined to endometrium only. Stage 2 is invasion of the cervical stroma, where the invasion of cervix also is involved, and a intrauterine extension with the involvement of the whole of the cavity, and aggressive type seen under microscope. Then similarly stage 2A, B, C is done based upon the histological evidences. Stage 3 is where there is a local regional spread within the beyond the meiometrium, and invasion of the uterine serosa as well as the adnexal, the whole lengthwise of the uterus being involved. Stage 4 is invasion of the bladder and intestinal mucosa, and there again you have subcategories like A, B, C based upon the extent. The general treatment recommendations of the endometrial cancer is as per the standard guideline. Again, I have just copied it from the guidelines of NCCN clinical practice guidelines on oncology. The treatment protocol is endometrial cancer is treated primarily with the surgery, that's a hysterectomy or bilateral salpingo-oophorectomy or abdominopelvic washings along with that, and lymph node evaluation and a lymph node excision if necessary. So primarily it's the malignant cells have to be removed. So if the patient is diagnosed at an early stage and there is no involvement of the ovaries, it is simply hysterectomy. If there is an evidence of involvement of the ovaries or the tubes, then salpingo-oophorectomy with the hysterectomy. If there is a tendency for involvement of the peritoneum, then pelvic washings, that's the identification. The lymph nodes, if they are involved, that also would be a part of the surgery. Then the best chemotherapy, there is no definite opinion, there is no general agreement, but chemotherapy may have to be done in stage 3 and beyond that. And in the patients who have very advanced conditions, the line Paxil, that's paclitaxel, a very toxic chemo drug, is often used as such. Then treatment during the therapy, to assess whether the patient has responded to the treatment or not, biomarkers like CA125 could be used as such. The CA125 level directly reflects the status of the malignancy, and whether it reduces or not can be direct assessed by CA125 level. Now survival period and the prognosis as per the SEER database, the collective database seen, would be 5-year survival rate of uterine cancer from 2008 to 2014 was 81.1%. From 2014 onwards, it's claimed that the survival period has increased slightly, but you have a very solid data between that 2008 to 2014. Now, of course, there was a typing error. It's 10 was more. It's the 2014 should be, the survival stage for the uterine cancer is based upon the localized when the stage in which the patient is treated. If the localized, which is confined to the primary site, the survival period was 94.9% as such, which constitutes around 67% of the cases. So early diagnosis and in 67% of the cases, and this has resulted in a survival period of almost 94.9, which is claimed to be very excellent results. Patients who have a spread to the regional lymph nodes, which is around 21% of the cases, the survival period is around 68.6%, 5-year survival period, I think. Then if the patient has a distant involvement, metastasis has it, it's around 16.3%, and unknown, where you may have all the other unstable conditions, 5-year relative period is around 15%. Now that's about the endometrial cancer. The next condition which you discuss would be malignant lesions of the ovaries. Now, malignant lesions of the ovaries are multiple, it's not only a single condition, and it may be the primary ovarian lesions, or there could be secondary as such. Now, among them, among the primary lesions, epithelial ovarian carcinoma, which is around 70% of all ovarian malignancies, is important. So, we mainly depend or focus on the epithelial ovarian carcinoma. The other primary tumors are germ cell tumors or sex-cord stromal tumors and other rare types as such. Now, metastases to the ovaries are relatively more frequent, particularly from the carcinoma of the cervix or carcinoma of the uterus, when the metastasis in the ovaries also can occur due to the droplet spread from the visceral organs like intestines, stomach or colon, or from the breast, which is also called as Krukenberg's tumor. Now, that's another type of the secondaries in the ovaries. Now, as per the incidence around the world, more than 2 lakh women are estimated to have ovarian cancer every year, and about 1 lakh die from the disease. The lifetime risk of a woman developing epithelial ovarian cancer is 1 in 70 as per the global data. Now, the tumors which are presented as such would be a majority, 90% are epithelial origin, and others which are less common are sex-cord tumors, which I just referred to, and their impression, how they look at it, that's how you can make out by clinical impression, visual impression would be, in a typical ovulation, you will have that phases of the ovulation, but the condition of epithelial cancer would be almost the same as that of the normal, but it seems to be extended with some irregular features in the cavity. Now, I will show you some of these examples, that morphological examples. Sex-cord tumors, stromal tumors, the mass, when you open the abdomen and see the ovarian mass, this is important because there is a possibility that you may open the abdomen and then see the ovarian masses, by which you can make out certain amount of the possible diagnosis. In a typical stromal tumor, the mass is hard and the cut surface is solid, and it may be having a whitish color, or there could be hemorrhagic appearance. When you look at the surface is smooth and shiny. That is the feature of a called stromal tumors. Germ cell tumors, they are again large, very large, average size is more than 15 centimeter, and their surface is lobulated. You will see fine these different sets of these irregularities, and soft tumor, and yellowish tan, usually having a yellowish color or cream color, or there could be some areas of cystic changes. When you cut through, there could be some areas of bleeding or necrosis also could be presented. And one more variety of the germ cell tumor is the teratoma. Teratoma is where there would be some different types of the cells, often hair or cartilages or bone, or very rarely the organs of the body could be seen in that. Very hard tumors, and when you look at the mass could be irregular or may have a cystic appearance, and when you cut through that mass, you will see some atopic tissue, a tissue which is either hairy often, or cartilaginous, or bone, teeth, etc. could be seen, which is a typical feature of teratoma anywhere. Of course, teratoma can occur other areas of the body, but ovary is one of the most common site of the teratomas. Then primary peritoneal carcinoma is where the patient may have a involvement of peritoneal involvement. The surface would be irregular, multiple setting, there will be multiple these irregular appearances, and the tissue will be very brittle, maybe fragile as such, and the tumor masses are quite big. Even it may be involving the peritoneum as such. There is a possibility of ascites. Patient may have a serous ascites. Fluid may be accumulated in the abdominal cavity. So that's how, from the operative point of view, you can make the guess as such. Other than that, it has to be essentially the microscopic diagnosis. As far as the incidence is concerned, in Asia, that in India related data, of course you may not have a very specific data about the Indian incidence, but Asia and Asia related data from the World Cancer Research is as per the data I have just copied it. Ovarian cancer is the 8th most common cancer in women, and 18th most common cancer overall, with 3,24,600 new cases and 2,06,956 deaths in 2022. The worldwide age standardized ratio is 6.7 cases per 1 lakh. And currently, the rates of ovarian cancer are falling in Northern Europe and North America regions that until the early 2000s they had the highest age standardized incidence. And they are increasing part of Eastern Europe and Asia. That's important. In Asian subcontinent, the number is increasing now. And 2022, the highest overall rate of ovarian cancer was in Latvia or Samoa in the second place. The 5-year survival period of ovarian cancer is, if it is localized, 91.9%, if there is a regional spread, 71.5%, distant metastasis, 31.4%. And the survival period also is depending upon the stage as such. In stage 1, it's 93%, whereas in stage 4, it comes to 30%, and overall survival rate is around 86%. That's about the data based upon FIGO and SEER data. Then reproductive factors, the causes as such. One of the important risk factors is parity, having multiple children. Risk of epithelial ovarian cancer is increased in men who have not had children, and possibility those with the early menarche or late menopause. As in case of the endometrial cancer, patients who are nulliparous, who do not have children at all, they also have a high chance of developing ovarian cancer, and those who have early menarche and late menopause also have a high chance of developing the ovarian cancer. Women who have been pregnant have a 50% decreased risk for developing the ovarian cancer compared with the nulliparous women. So it's almost double in nulliparous. Multiple pregnancies often increase the protective effect. If the person had multiple children, then the ovarian cancer chances are much lesser. Oral contraceptives use decreases the risk of ovarian cancer significantly. Now that's a very interesting issue. The oral contraceptives increase the risk of endometrial cancer, but ovarian cancer incidence is reduced. These are statistical observations. Now the interesting is these are all statistical observations. There are no other standard rational background around it. Genetic factors also are well known. Family history is one of the important factors in ovarian cancer. Lifetime risk of developing ovarian cancer is 1.6% in general population, whereas the risk risk is increased by 4 to 5% in first degree family members, and if the more than one relative is involved, then risk is involved up to 7%. The other factors which are known, again certain of the controversial issues, because of the issues are controversial, I have given you the references also. The patients who use hormones and the incident rate ratio for ovarian cancer is around 1.38 compared with the women who never took hormone therapy. So if we have taken hormone therapy any time, the risk increases by about 1.38. This is based upon the data, you have the reference there. And there is a fair evidence that increased adult height and body mass index also are associated with the modestly increased risk of ovarian cancer, and that's also another of the references. Like endometriosis has been also is linked to increased risk of ovarian cancer, and use of talcum powder on the vulva and perineum also is associated with the increased risk of cancer. Now this use of talcum powder over the area producing ovarian cancer has become a major news issue just 2 years back. Then some American women filed a suit on Johnson's factory for that Johnson's powder, and she could win the case and got some significant compensation. The metastatic disease often is found in the peritoneal surfaces. The spread would be in the peritoneal surfaces, and usually the location will be on the under surface of the diaphragm and paracolic gutters. Now, under surface of the diaphragm is one of the area which is difficult to be examined and often produces certain odd symptoms, and hence that has to be important. And the cul-de-sac, that's the pelvic cavity. Other common sites are surface of the liver, mesentery, omentum, uterus, and pancreatic lymph nodes. Extraperitoneal spread into the pleural cavity, lungs, and groin lymph nodes also do occur. The clinical symptoms of ovarian cancer are quite vague. The most common clinical symptoms are bloating, that's the patient who have abdominal distension and discomfort, and due to the pressure effects on the bladder or rectum, the patient may have a difficulty in micturition or difficulty during defecation, so on. Constipation could be the other symptom. Vaginal bleeding. So, if there is a vaginal bleeding, of course, you may suspect that the pelvic pathology, but in other conditions, it's quite difficult. Who have indigestion, acid reflux, shortness of breath, tiredness, or weight loss, early satiety. These are vague symptoms of ovarian cancer, and hence it's quite difficult to make out. The physical findings also are uncommon. It may not be possible to make out by clinical examination most of the times, and only when the condition is advanced, there could be in a palpable pelvic mass, ovarian mass, or signs of ascites, pleural effusion, or abdominal mass or intestinal obstruction. So the criteria to make the diagnosis, the National Institute of Health and Care Excellence, that's NICE guidelines, recommend that a patient having a symptom of persistent abdominal distension, and particularly more than 12 times per month, or early satiety, pelvic or abdominal pain, increased urinary urgency or frequency, they have to be evaluated for the ovarian cancer if the patient is more than 50 years old. That's one of the guidelines to make the diagnosis of ovarian cancer, or to not to miss the ovarian cancer diagnosis. If a patient has these symptoms like persistent abdominal distension, early satiety, or loss of appetite, pelvic or abdominal pain, increased urinary urgency or frequency, then the patient has to be evaluated, and there is a possibility that the patient may have ovarian cancer, particularly if the patient is more than 50 years old. To make the diagnosis again is difficult because most of the times the investigations are not sufficient, the particularly imaging studies are not sufficient, and to select which type of the imaging studies are done, again there are certain guidelines. Ultrasonography is considered as a first line imaging of head neck cell studies, and the advantages are it can be used for transvaginal examination, and the limitations are the extent of the disease or early stages. Small lesions may not be possible to make out. MRI is usually to make out exact characters where the condition is not really made out. In such conditions, MRI could be useful to make the diagnosis of head neck cell masses. Confirmation of the ovary as origin of the mass, whether when I see a mass, whether it's a ovarian mass or something else, that can be confirmed with the MRI. And if there is a possibility of ovarian torsion as accompanied mass, that also is made out by MRI much better than ultrasonography. Ultrasonography may not be able to make out that accurately. CT is evaluation of the extent of the disease. So CT is done when you have already made a diagnosis of ovarian cancer, and to confirm the extent and evaluation of the lymph nodes, CT is better. And the investigations mainly should be based upon what you see in the gross. Epithelial cancer, because it is a soft lesion, in the ultrasonography you may be seeing as a soft cystic lesion. Germ cell tumors, harder masses, that hard mass with the dense opacity seen in the ultrasonography. And the stromal tumors, sex cord tumors, they will show compartments, multiple densities seen in the ultrasonography. And ovarian metastasis can be confirmed by MRI, where you can see the metastatic lesions over. From the ultrasound, because we depend mainly upon the ultrasound most of the times to make the primary diagnosis, the ultrasound features of ovarian cancers are when there is a irregular solid tumor, it's a sign of malignant. If the ovaries show abnormality, if there is a presence of ascites, that also is a sign of malignancy. These are called as M signs. M signs are malignant signs. In ultrasonography, the criteria of making that ultrasonography signs, particularly when there is a mass in the ovary, to confirm whether it is a benign or mass, or benign or malignant. If the mass is having only a single chamber, unilocular, then it's a benign, B1. And if there is a presence of solid component, with the largest component has a diameter of less than 7 millimeter, not more than 7 millimeter, then it's a sign of benign. If there is again papillary structures, the surface is irregular, having a papilla like, then it's a sign of a malignancy M3. And if there is irregular multilocular, multiple locules there, and the largest diameter is more than 100 millimeter, then it could be more of sign of malignancy M4. And if there is excess of blood flow, very strong blood flow seen on the color, then it's a M5. And similarly for benign, if there is no blood flow, its score is 0 or score is 1. And the smooth multilocular tumor, then it's considered as B4 sign of benign. If there is a acoustic shadow, that's a solid shadow in the middle, then that too is a sign of the benign conditions. The impressions, image which you may see under benign malignant comparison, a unilocular ultrasound image and the multilocular lesion sign of the malignancy. The benign, the green one, the upper ones are benign, the lower ones are sign of malignancy. Presence of a solid component which is less than 7 millimeter, a presence of a solid component which is beyond that 7 millimeter and having irregular consistency. Acoustic shadows, that's a solid shadows in the middle. Instead of that, there could be polypoid structures, irregular polyp-like structures in malignancy. And the smooth multilocular tumor in case of the benign, whereas the multilocular lesions with the irregular shapes and surfaces are sign of malignancy. And not much of an increase in the blood flow is a sign of benign. When there is an increase in the blood flow, it is a sign of malignancy. Now, so that making that diagnosis of ovarian cancer based upon the imaging studies is needs a careful assessment and certain experience. MRI scan gives you somewhat better idea about the consistency of the ovarian mass, soft with the irregular opacities, or multiloculated lesions with the irregular opacities. The other evidences also are based upon the tumor markers. The tumor markers are mainly CA125 or HCG, human chorionic gonadotropin, or AFP, alpha fetoprotein also is used as the tumor marker. And depending upon particularly epithelial ovarian malignancies, CA125 is considered as one of the dependable tumor marker. Staging is done as usual by the T1 stage 1 where the tumor is limited to the ovaries. Stage 2, tumor involves one or both ovaries with the pelvic involvement. Stage 3 is tumor involves one or both ovaries with the peritoneal metastasis. And stage 4 is when there is a distant metastasis including the liver parenchyma. Then some subgroups based upon again further grades of these involvements. The grading also is done based upon two issues. Now, from the clinical point of view, all ovarian cancers are categorized into two categories: low grade serous carcinoma and high grade serous carcinoma, particularly epithelial carcinoma. And they are also named LGCSC and HGSC. To confirm whether it is a low grade or high grade, which has a significant difference in the prognosis. Once you have made the diagnosis of ovarian cancer, it's necessary that you make out whether it is a low grade or high grade variety. And the clinical evidences of this high grade and low grade is if the patient is having age of 45 to 57, that's a relatively younger age, it could be low grade. Later ages, it tends to be high grade. If the patient is having a stage of more than one as such, and if it may be high grade or low grade as such. If there is a bilateral involvement of bilaterally, the low grade chances are 77%, whereas high grade chances are 84%. If the growth pattern is there is a papillary features, then it could be low grade. If there is a large papillae or solid masses, then there could be a high grade variety. If there is no necrosis of the tissue, it may be low grade. If there is a high necrosis, it is a high grade as such. If under the microscope, if the nuclei are larger and mitotic index is lower, then it's low grade. If it is a higher, then it is a high grade. So microscopic picture also is important. And the other possibilities in advanced conditions, in vitro drug resistance assays also are done. In vitro, the sensitivity to the chemical chemo drugs are done on the cellular study. If that shows a drug resistance, it could be low grade, like particularly paclitaxel resistance, which is done in advanced conditions for oncological practice, which is not done regularly in our routine clinical conditions. And in case of high grade, the drug resistance is lower, and 50% 5-year survival period for stage more than stage 1 conditions, advanced stage conditions. In low grade is 40 to 56%, and high grade is around 9 to 30%. And low grade ovarian tumors are treated with surgery, chemotherapy, hormonal treatments, and targeted therapy, whereas high grade tumors are treated with chemotherapy, hormone therapies, and bevacizumab, that's the immunomodulator drug. That's about the ovarian cancer. With this we conclude today, and we continue with the uterine body tumors in the next session. If there are any questions.